Hit record. Okay. Terrific. Welcome everyone to the launch of the N3C Open House week. It's actually maybe more like a few weeks, and you'll be hearing about what that means and why throughout the talk today. This is really this program today is really geared towards helping people become acquainted with the N3C program and helping people find their way to the clinical domain teams, learning a little bit about the N3C cohort characterization as it stands today, and seeing a quick demo of the system. And so we're just going to quickly go over the agenda. I'll start off here today. Then we'll hand it off to David Ellison, who's going to talk about his experiences in participating in the kidney domain team. You'll see the demo from Ben Amor. And then we're going to have some of the domain teams, pregnancy and diabetes and obesity, talk about their experiences and the science that they're doing to hopefully inspire you in your own area of science and interest to bring your questions to the N3C. And then we'll have some how to get involved information, more on trainings, making sure that your data use requests make it through efficiently from our Assistant Director, Anita Weldon. And then Dr. Chris Shute will make some closing remarks. Next slide. And so I just want to introduce Dr. Ken Gersing, who's going to kind of go over a few of our statistics. He's the co-lead of N3C with Dr. Chris Shute and myself, and is the director of informatics at NCATS DCI. Take it away.
Thank you, Melissa. And as I'm speaking, I was just getting off a call on an advanced training. So Melissa referenced this. So as this is really an introduction and just to let folks know as they dig in, there are other trainings available and videos. So just real quickly, I want to make sure people really understand what N3C is. And this slide is, these graphics are done by Julie McMurray, and I think they're just wonderful because they take a very complicated process and make it in a digestible format. What Julie's describing here is N3C is made up of an enormous community of, I'm going to call them data contributors. These are CTSAs, community hospitals, and the CTRs, which are rural hospitals. They have agreed to lend us their data. It is their data. We are the stewards of that data. They send it to us in one of 4 models, and the other that's at the bottom is a 5th model called FIRE that we're working on very actively. So we can take the data as OMOP or active trinetics or per CoreNet. And then as you can imagine, these are different data models. And then Chris Shute and his marvelous harmonization team do an enormous amount of mapping, both semantically and syntactically, to place the data in a common repository. And we're using OMOP as that common repository for lots of reasons, the least of which is the community is very large and supportive, and has a lot of wonderful tools to use. And then we place it in this enclave, and I want to use the word enclave because as Dr. Kurilla, the head of DCI, says, it's a Roach Motel. The data can check in, but you cannot check out. And this is on purpose. This is sensitive data. And so we are happy to supply tools and let people use it. But it has to be done in the enclave. So next slide, please. Real quickly, I just want to thank, it is hard to explain the amazing team that Melissa and Anita and all of the people have put together. We have well over 1,200 people who have volunteered to help put this together. And this is a timeline. It seems in COVID time, I know it feels like years, but in fact, we kicked this off in April. And just to zip forward on the slide, if you see, we kicked off in April, but by December of last year, just a few days ago, we had 75 data contributors who had signed DTAs, 139 institutions that had signed up to use the data. We had 140 unique projects, which represented actually 38 sites of available data now. and that included some rural data. And that also is, at that time, was 516 active investigators. As of this morning, I looked, was 723. 15 published papers that are in publications or in review. So, and we have 2.9 billion rows of data now. That's almost a 500,000 patients. So plenty to work on, amazing amount of community. So thank you, thank you. Next slide, please. So this is just my last slide. This is as of this morning. You can see we've just crossed 500,000 COVID positive, almost 2.7 total patients. Obviously, those include controls. 39 sites out of the 75 have been harmonized, curated, and are available. That's about 3 billion rows of data. So we're really, really excited, and I just can't thank you enough for this. Is a terrible pandemic, but we feel very strongly that this is a resource that's available for really anybody to use. And we thank not only people who contributed and harmonized it, but the people who are doing the science. Next slide, and I'll hand it off to you, Melissa. Oh, that's true. So at the rate now, we'll be at about, once all these sites are in, we're expecting, close to 8 billion rows of data. Very exciting. Thank you.
Thanks, Ken. So I just wanted to talk really briefly about the cohort itself and the work that the cohort characterization team has been doing. We have a preprint that has been posted just recently. There's a bit.ly to the preprint listed there. And so these are just some of the figures that have been created for that preprint and are being used to help design a public-facing dashboard for the website that will be available maybe within the next 10 days. So you can see over there on the left, we have a severity scale. Creating the harmonization schemas necessary to harmonize severity from all the different sites was quite the challenge. And so it's really terrific to be able to look across the nation and classify patients as one key variable in terms of their severity. And so here you can see the percentage of patients with the different severity characterizations. And then these are used throughout the rest of the cohort characterization in order to look at the correlations between severity and drug use, pre-existing conditions, and those sorts of things. So just one example of that is over there on the right, where we're looking at changes in antimicrobial use or immunomodulation drug use over time. In the different categories of patients. And so you can kind of see how systemic antibacterials have use has gone down. And you can see other drugs such as remdesivir have gone up as the pandemic has proceeded. And so this is also sort of a very interesting lens through which to view the way our healthcare system has worked in terms of, changing use guidelines and care differences across the nation as well when in the face of new disease without sufficient care guidelines. Next slide, please. So I just wanted to kind of explain one outcome of having the cohort and all of these harmonized variables and harmonized data is the capacity to use these data for large scale analytics. And you'll be hearing more about examples of this throughout the domain team's discussions. But as part of this cohort characterization, which was led by Dr. Tel Bennett from the University of Colorado, CTSA, they built a machine learning model based upon the first day of vitals and other variables that are easily measured in any healthcare setting to predict the severity outcome. And so using a number of different machine learning methods, we can create this first day model to predict patient severity that can be deployed in any context with high confidence in a repeatable manner and a clinically relevant manner that can help provide clinical decision making to people in different kinds of care settings. And it's also readily deployable and easily refined in the face of the new data and the new changes that we will see as the pandemic proceeds and care changes over time. So many thanks to Dr. Bennett for leading this initiative and really helping us understand how these data can be utilized both from a clinical perspective as well as an informatics perspective. So I will hand it off now. If you'll go to the next slide. to Dr. Ellison.
Well, thank you, Melissa, and thanks to the team for inviting me to participate. While I am a PI of the Oak Tree, Oregon Clinical and Translational Research Institute, I'm presenting this really as in my day job, which is as a clinical nephrologist, because my involvement with N3C, while I do have some involvement with the program, what I'm going to talk about today is really much more has to do with my role as a clinical nephrologist and the fact that I've seen a lot of acute kidney injury when I've been on service. So if you could advance to the next slide. So in the kidney community, we sometimes feel like we're the poor stepchildren, and we don't get as much attention considering how mortal kidney disease is. But I think that the N3C pandemic has really begun to change that, and there's been a lot of recognition that kidney injury is very common in the disease, and frankly that the availability of renal replacement therapy like dialysis or continuous renal replacement therapy has been a limiting factor in treating patients across the country. These are just from 2 articles from the New York Times. One is on the left, just specifically stating that an overlooked cause is the dire need for kidney dialysis. And on the right is another article about a relative of someone whose relative was not able to get dialysis in a timely manner, and that certainly limited the prognosis for that patient. And my own personal experience being on service is that we see a huge number of patients with acute kidney injury in our COVID population here needing dialysis. Many of them are on ECMO, so it often goes together with pulmonary injury. But this is really an interesting pandemic in terms of its effects on the kidney. I just this morning searched PubMed, and since just in the last year and a half or a year, whatever, since the pandemic started, I searched for acute kidney injury and COVID-19 and came up with 273 papers already about this topic. And yet here's the problem that's concerned me and others, and I think that N3C provides a potential opportunity here. There's a recent consensus document of the COVID-19 associated acute kidney injury working group, which is a subgroup of a large kidney working group. And they report that rates of AKI vary considerably between studies, with higher rates reported in countries outside of China. And they talk about all the variability and the risk factors. And there is a sense that the risk of acute kidney injury is declining with time. It comes back to the kind of graphs that Melissa was just showing. So we're getting these piecemeal reports from all over the country, which are providing interesting data. And I think many of us have a sense of what's going on. But what we've really lacked is a cohesive database that allows us to get a realistic snapshot. And most importantly, in this consensus report, they point out that the definitions of acute kidney injury used in the various papers are completely different. There's no standardization. And so it makes it very hard to compare apples and oranges. And I think that the N3C can help us to address that. Next slide. This next slide is just intended to show very, very simply how easy it was for me to get involved. Again, even though I'm involved with N3C because CD2H is homed here at OHSU, that had really nothing to do with how I got involved in this project. I just went on the web and looked for who is looking at acute kidney injury with regard to N3C, and found Sandeep Millipatu, who I'd known a little bit through other channels, and I just sent him an email. And within a day, he said, "We would love to have you as a member of our team. Here's how to register, and we'll get you signed up for our meetings, which happen every Wednesday." And so the following Wednesday, I was able to start participating. It so happened that OHSU, we've been working on getting our data into OMOP and then uploading it into the database. But my involvement was really not preconditioned on the fact that we're uploading data into the database now, but just was because of my interest. And I think that's an important point I want to make. It's just interest that we need. Next slide. So this is the acute kidney injury team. This is part of it. There's actually more people on it than this, but I couldn't get them all on the same slide. But I think that a couple points I want to make about this group. for me, this has been an opportunity to interact with a group of real leaders around the country. I don't count myself as one. My own translational research is more in the area of electrolyte disorders and hypertension. But because of my clinical interest, I was able to reach out and then begin interacting with people really across the country who are tremendous experts on acute kidney injury. This group is led by a group at Stony Brook, which has already generated its own sort of piecemeal paper, and that's led by Sandeep and Farouk. And they're both clinical nephrologists, research nephrologists who have been outstanding in really leading this effort. But the other person on the group from Stony Brook, and this has been one of the other points I want to make, is Richard Moffat. I don't come from a background of strong informatics expertise. And I think it's useful as a tool, but I don't plan to become an informatician. Richard is an outstanding informaticist. And despite the fact that he's really busy, for example, he was co-booked at today's meeting, so he couldn't be here, but he spends an hour with us every Wednesday, and he's in the Palantir data set. And we ask him questions, and he's able to pull up things and change things and examine things in real time. And that's the most exciting thing for me. We also have representation from the NIDDK, Yvonne Schulman, who's on pretty much every call, and that's great. And then it brings together other leaders from around the country. Chirag Parikh is arguably one of the top 1 or 2 experts in the country on acute kidney injury from Johns Hopkins. And then he has another data scientist, Stephanie Hong, who's from Johns Hopkins, Fei-Fan Liu from UMass, and then me. And so we have a balance of people who are nephrology clinicians, informaticians, people from the NIH, and then Brian Bird is a cardiologist who has an intense interest in the connections between the heart and the kidney. And again, he's just someone who sent an email because he's interested in this problem and has been added to the group. So it's an exciting group to meet together with and share opinions between each other. And I can't emphasize strongly enough what an enjoyable time we have every Wednesday when we meet. And so, what we're trying to look at are I sort of alluded to before, the premise is that kidney injury contributes importantly mortality and leads to long-term morbidity. Obviously, one thing we're interested in looking at eventually, this is a little more challenging, is the long COVID syndrome. And for the kidney disease, long COVID is either CKD or end-stage kidney disease. And so we're hoping to look at that. But we're looking at some not so surprising things, but these are really interesting. What will predict acute kidney injury early on? Are there regional differences in AKI incidence? That was mentioned before, but we can really look all over the country and see how AKI varies. And we think already that there are substantial differences. We're looking at whether the AKI incidence during the second surge is similar to what it was during the first surge. We have impressions, but this data will really allow us to do it. And what are the predictors of ESKD, of end-stage kidney disease after AKI? So there are lots of other things. We talk a lot about making definitions of the kidney-related syndromes that have traction and can have staying power and that align with standard definitions across the country. And I think that's one of the things that will come out of this. We don't have any data to publish yet, but we're really making good progress on getting things going. And I think this is an exciting opportunity for any clinically oriented person to get involved. And I would just encourage you to reach out to the domain team that's relevant to you and get involved, because it's really been just tremendous fun for me. And I hope I have something to add to the group, and I'd encourage you to get involved. So just pass it back to the other group members of the team, but I just wanted to express my enthusiasm for the whole project.
Thank you, David. So now we're going to jump on to Ben. And I also just wanted to just quickly mention how, David's work on the kidney project is really illustrative of how all the different domain teams are working in order to leverage this diversity of expertise. And so we hope that's inspired you in terms of what you can do in your domain teams. And you'll hear from a couple of the other domain teams, as I mentioned. So onto our demo.
Okay, thank you, Melissa. Can you give me a thumbs up if you can hear me okay? Perfect.
We hear you perfectly.
Okay, I will start sharing my screen then. So this is going to be a real whistle-stop tour of the enclave. And so it will probably seem very fast. I apologize for that. But as Ken mentioned, there are lots of other trainings available, and we can, we'll send out information about all of those. And there's lots of training available in the platform, and I'll point that out as well. But I'm going to start here in the homepage. So this is a live version of that view that Ken was showing us earlier that tells us how many patients are in the enclave, how many of them are COVID positive, and then how many records of all these different types we have. And this updates whenever the data updates every week. And so you can kind of keep track of, what do I have to play with, what information is available. And it's been really good to see this number just grow and grow from zero 6 months ago up to now over 500,000. So from the homepage, I've got these tabs at the top, training and discover. These are really useful. The training page, because it will link me to the places inside the enclave where I can start to do different kinds of training and learn about how to do all the things I'm going to show you today. And so following the training portal link, this is very much a work in progress. We're continuing to add to these, but there's been an awful lot of work done by the N3C team to build some introductory modules. So this first one, Enclave Organization, really just explaining how the Enclave works, how it's organized, where to find data, and how to do some sort of basic workflows. Then there's a slightly more advanced module all about OMAP, the data model that the data is represented in, and how to do some basic analysis of that. And then these gradually increase in complexity, and there's modules around concept sets, which we'll look at in a lot more detail, how to use code workbooks for doing coding, and how to use the knowledge store, which we're beginning to build up now, this library of artifacts generated by the different projects, and in particular, the cohort paper project that we heard about just now, that other people can start to use and leverage for themselves. But going back to the Discover tab, so this links me to some of the key places in the enclave where I can actually start to find data or start to find things like concept sets or the knowledge store. And so the data catalog, if I follow this link, this is where there's many different collections, different types of data that is available to you. So you'll only see the data here that you have permission to access. So I've got slightly more than you'll probably have because I'm an admin user. But you can see things like there's a collection for the de-identified data, there's a collection for the limited data set, there's a collection for all of the data sets available in the knowledge store. There is a data set for public data that's been brought in that's related to the social determinants of health. And if I click on that collection, now I can see all of the different data sets that are available related to social determinants. And so we can see things like counties, information about counties, information about food access and things like that. And if I go back to the data catalog, we can take a closer look here at the synthetic data. So I'm not going to show any patient level data from the real data sets, but we do have this synthetic data. And so we can take a look at what some of these data sets look like. So let's open up the person data set just to understand what does this actually look like. Essentially, this is just like a SQL table or a CSV that has rows and columns. And in this case, the person table has a row for every patient, and then it has columns for their gender, when they were born, what their ethnicity is, and so on and so forth. And so from here, I can now start to import this data set into a workbook or some kind of other analysis tool and do some further analysis. Or if I just want to get a very quick view of what's in here, I can click on a column and it can show me actually the distribution here of male and female. In this case, we only have 116,000 in the synthetic data, but in the real person table, this would have 2.5 million rows, and I would be able to sort of explore the various distributions of ethnicity and race and so on. So from here, let's take a look at an actual project in the platform. So let's take a look at the cohort paper project that Melissa was describing and that Tel and Richard have really been the driving force behind. So once you've been through the governance process and your project has been approved for the enclave, you'll get this sort of project homepage that will be created. And this project homepage is accessible to anybody to see, so they can see what you're working on. And it's got links to the workspace in which you're actually going to do your analysis. And that will only be accessible to the people who are part of the project. So that's kind of your safe enclosed workspace. But you can also connect up all of the various different sort of knowledge artifacts that your project is creating. And so what we can see all of the researchers that are a member of this project. And so we'll see some familiar names like Tao there. And we can also see all of the various different data elements that the cohort paper has been defining. And so in this case, they've done an awful lot of work to define 167 concept sets, which are really just ways of defining key data elements like lab measurements for blood type or the diagnosis codes that are actually used for COVID. And we can also see all of these different knowledge objects, and we'll explain in a little bit what these knowledge objects really are. But what's really important is that this is work that the cohort paper has done to do things like selecting the most critical visit for each patient that is actually the one associated with their COVID diagnosis. And now that's available for anybody in the enclave to use. And we're working through the process now of making everything the cohort paper has done that is really useful accessible to everybody in the enclave. The other thing you can do here is provide links to some of the most important files and resources from the project. And so what we have here is the characterization of the N3C cohort report with all of their sort of final tables and visualizations. So I'm going to open that up. This is not the actual N3C cohort paper report because I've just slimmed it down to look at one thing in particular. This is only accessible at the moment to people who have access to the cohort paper. But potentially, once a project is finished, there is a way of then opening up access more broadly if you would like your results to be available to the broader community. And I will just remind you, there's this cross here. These results are still in the process of publication, so please no photos of these. But really just wanted to give an example of some interesting work that the cohort paper has done, which is to very carefully define lots of the key lab tests. And in this case, they're vital signs, but they've also done it for blood measurements that you're interested in tracking over the course of an inpatient stay. And so what we're looking at here are some of those key vitals: heart rate, respiratory rate, temperature, and so on, blood pressure. And we're looking at, for an inpatient stay, the trajectory of these vitals broken down according to the severity of the outcome that the patient had. And so what we can see is there's some very clear patterns. For example, if we look at respiratory rate, people with severe outcomes or who actually unfortunately died come in with high respiratory rates. And we see that the people who end up dead, actually that increases over time, whereas the severe drops over time. And people who had mild or moderate outcomes actually start off lower and sort of trend downwards. And we can see similar patterns across these other vitals. And this is something that actually went into the predictive model that Melissa was describing that's actually been a really interesting result. Now, the details of this is not really what matters, but I just want to point out a few things that are nice about how the enclave manages this. The first is the reproducibility and the sort of auditability of this result. So what we can see here is we have a link at the bottom to the actual analysis that has produced this particular plot. And so if I follow that link, that's going to open up now a workbook where you can actually write code, you can write SQL code or R code or Python code. You can create visualizations like this one. And so what we can see here is the actual code that's been used to produce this particular plot. And in this case, this is some R code. And we can see the actual data set that's gone into it. And this is an aggregated data set that's already been aggregated over all of the patients in order to produce those average values for the different cohorts. But I can go further than this. And if I want to understand, well, actually, how did we calculate these average values? Then I can explore the full data lineage for this particular data set. And that will open up a sort of a governance view, what we call the data lineage view, which is automatically tracking every single step right from the raw data all the way through to this final data set that contains the aggregated values. And we can see some information here, like who produced this data set. And shout out to Richard. He already had a shout out, but I will second what David said. He is a fantastic informatician, has done a lot of the work here for the cohort paper, and he's very sort of happy to help people. So I'd encourage you to reach out to him if you want to learn more. And we can track every single step that's been used to produce this particular table. And at any point, we can examine the code, or we could examine the actual data, which I'm not going to show today. And we can keep tracking this all the way back, all the way to the full history, and I could expand all of the upstream parents through all 157 steps and transformations that's been used to produce this particular figure. So how can we actually start to use some of this work that the cohort paper has done ourselves? So as I said, a lot of work has been done in order to actually define what do we mean by a test for respiratory rate? What do we mean by a test for heart rate? It sounds simple. It really isn't. There's probably 10 different LOINC codes you could use for heart rate. And the cohort paper has done a huge amount of work in order to create what are called concept sets, which define the exact set of tests or codes that you want to look at for any particular vital sign or lab test or diagnosis or whatever it is you're interested in. And those are available for anybody to start to use straight away. So if I go back to the homepage in the Discover tab, we've got a link here to the concept set browser. And so if I open that up, that's going to show me a sort of full library of all of these concept sets for all of these different definitions that have been created. And there's nearly 1,000 of these across the different domain teams. And I can search across them by keyword, or if I'm interested in those that have been produced by a particular project, I can choose to instead browse them by project. And so now I can search explicitly for the cohort paper and say I want to look at the concept sets that the cohort paper has defined. And now I might say, okay, I know that they've defined the temperature concept set because I've seen that chart. And so I'm going to have a search and find that there's 2 different temperature concept sets, and I can see this one was the most recent one. So I'm going to take a closer look at this one. And so now this opens up a very rich view of not just what codes are corresponding to temperature, what LOINC codes, but sort of a lot of metadata about this concept set as well. And so we have the concept of versions of the concept set. So over time, we can improve it. If there's codes that are missing, they can get added in. If there's those that shouldn't be there, they can get removed. In this case, though, there's just one. And so I'm going to open up the first version of this. And I can see the 27 different codes that are included in it, all different types of temperature. And I have this dashboard, which will actually allow me to understand how these are used in the real data across all of the different sites. So we get this sort of heat map that shows us for the various different codes, how are they actually being used? And we can sort of see that there's this one code here that's more common than all of the others. And we can see how many unique patients there are at each site that actually have a corresponding measurement. And we can see that actually there are some sites that seem to be missing body temperature measurements. And so that might be important for us to understand for our analysis. We can also see that there have been a number of reviews done of this concept set by Harold from GHU, who's basically confirmed that they're comfortable with the concept set as it currently stands, and hence it has been used in the cohort paper. So how do I actually use this in an analysis? Well, I'm going to have a sort of quick look at how we could create a brand new analysis from scratch, filter down to look for body temperature measurements, and then do a quick visualization of that. So I'm starting here in a blank workspace. So this is what it would look like when you've just been granted permission for your project. And I'm going to create a brand new workbook. And in this workbook, I'm going to be able to import the data sets that I want to use, in this case, the measurement table. And I'm going to be able to use a template which automatically will filter that measurement table to the concept set that I'm interested in using. So I can hit the big blue import dataset button, and then I can go to the data catalog that we were looking at earlier. And I can find, in this case, I'm going to use the synthetic data. But if you had an LDS or a de-identified project, then you could go to that collection. So I'm going to go to the synthetic data here, and I'm going to pull in the measurement table. So now I have the measurement table. We have 1 row per measurement, but I want to specifically filter down to the measurements that correspond to body temperature. And I want to use this concept set in order to do that. And so I'm going to do a new transform, and rather than having to write code myself, I'm going to use one of the pre-built templates. And so we have a template here that I've starred because I use it quite a lot, which allows me to filter an OMAP domain table to a particular concept set. And so when I click on that, it brings in a helper table that it needs, which is the helper table containing all of the concept sets. And now all I need to do is fill in the blanks here of which column am I filtering on, which is the concept ID column, and what is the name or the ID of the concept set that I want to filter on. So I'm just going to go back to the concept set here, grab its ID, and then copy that in here. And now I hit preview, that's going to filter down my measurement table just to those measurements corresponding to body temperature. Now, rather than while we're waiting for that to run, the next thing I might want to do is say, well, okay, I only want the measurements corresponding to those inpatient visits that are related to COVID, because I want to produce some chart like the one I just showed you from the cohort paper. Now, in order to do that, I'm going to need to know what those critical visits are. And that's where the knowledge store comes in. So going back to the home page in the Discover tab, we have a link to the knowledge store. And if I follow that, it opens up a view like this. It's a little too complex to go into what the knowledge store exactly is, but basically it's a place where we can put these definitions like what's the critical visit associated with COVID, or what outcome did each patient have on that visit in a place that's shareable and discoverable. And so if I filter down now to the knowledge artifacts produced by the cohort project, I can see there's a few. Some of them are visualizations for doing things like violin plots of measurements. Some of them are cohorts, such as the lab confirmed positive COVID patients. And one of them here is the select critical visit knowledge object. And the description here explains basically how the logic works to identify what the critical visit is. It shows me where there's a template that I can use myself if I want to run the same code. But there's also a data set in the data catalog, which I can just import into my workbook and start to use for selected critical visits. And so if I went back to my workbook, we now finished this filter. So that now is just containing the temperature measurements. Now I can import a new data set. I go to the data catalog. I'm going to go to the knowledge store collection, and I'm going to import selected critical visits. I'm not actually going to do it because it's got row level data in it, but that's what I would do. And in order to show you what that would eventually look like, here's one I prepared earlier. So this is the first step that we just did, filtering down to the temperature records. And in this case, if we did that against the LDS data with 1.5 billion rows, we'd find that there's 53 million temperature records. And then this is the critical visits data set that we just imported from the knowledge store. And now we can join those two together and we find the temperatures associated with the critical visits. And we've got about 5 million of those. And that was a very simple step of doing a join. And now we use one of the distribution boards. And so this is just a point and click visualization board, which will produce me a distribution of these. And now if I want to create a new report, then I can add this to a report. I can find the workspace that I'm working in, which in this case is the example research project, but this would just be the workspace created for your particular project, and then call it something boring like temperature report. And now I've created a new report in the platform, just like the cohort papers one. I've added this distribution of temperatures from critical visits. And now I've basically got a live report that whenever we get new data in from any of the sites can automatically update and sort of evolve over time and show me how this temperature distribution is changing as we add more and more data in sort of just a few clicks, and actually without really having to write much code myself, because I've been leveraging some of these templates and some of these knowledge object data sets that already exist. So that's the end of my whistle stop tour.
Terrific, thank you. Okay, we're going to try to speed us along here. Hopefully you all are impressed by all the amazing things you can do in the Enclave, and we look forward to seeing you invent new ones. So on to our domain team flash talks. Next slide. So next we're going to have Elaine.
Hey everyone. I am, are my slides going without my permission? Hopefully not. I am co-champion. Yeah, you can do the next slide. Sorry. I'm co-champion with Reena Patel, and these are some of our active members of our team. We meet on Mondays, 1 p.m. Pacific and 4 p.m. Eastern. We are really excited to be talking to you today about what our team is up to. We're particularly hoping to add members, and if there's anyone on this call or you know of anyone who's interested in pregnancy and COVID, please go to this link. There's information about how to join our Slack and our team, and I'm the primary contact. So we have our data use request DUR in place, and so it's very easy to have folks join. Currently, we're using the de-identified data with the hope that down the road we'll transition to limited data set once people get their IRBs organized. Next slide, please. So the mission of our team is to leverage the N3C data to gain insight into pressing COVID-19 questions around pregnancy. And while there are probably countless questions to ask in our domain, we identified 4 sort of broad areas that we really want to tackle first and foremost with our domain team. So the first question is around incidence, timing, and severity of COVID-19 amongst pregnant women in the N3C cohort. And we also have interest in understanding if within the N3C data are pregnant women at higher risk of incident infection. Our second question is related to how infection may be associated with maternal and infant outcomes. I do want to note that one of the challenges for this particular question is that we don't currently have an ID that links mom and baby, but there are some concepts or codes on the maternal record that could indicate infant health. So we're sort of starting with those to define some infant outcomes that we would see on the mom record, with the hope that down the road we would figure out how to link them to look at sort of the baby outcomes more directly. And there is a team that's working on the pediatric side, and so we hope to collaborate with them in the future for questions that overlap. The next area is focused on within women who have COVID-19. You know, is there any issues around treatment for COVID for women who are pregnant and these maternal and infant outcomes? And then lastly, which is sort of the area that I'm particularly interested in, is understanding maternal characteristics, clinical and environmental factors that may be associated with COVID-19 severity among pregnant women. Next slide. So the first project, and I put this in quotes, is defining pregnancy in N3C. So we've been working on this for a number of months, and we've been we've finalized sort of our version 1 pregnancy cohort just this morning. So this has been an ongoing effort, starting with the literature around using Odyssey resources to identify pregnancy concepts and various methods that have already been validated in the literature. And we also are using machine learning techniques to identify importance of various features for identifying pregnancy. The reason we have explored using machine learning for our cohort definition is because as we add more and more sites to the N3C data, it's harder and harder for us to do sort of a concept by concept assessment with a clinical input. So using the machine learning allows us to sort of narrow to those most important concepts and use that data driven approach in concert with our clinical colleagues to then look and identify those concepts that are most important. So one of the reasons this has been most difficult is because pregnancy is a transient state. So some women are pregnant just for a few weeks and miscarry. Some are pregnant for the full term of 41 weeks, but then they're not pregnant anymore. And so figuring out how to identify them during pregnancy is complicated. And then it's also complicated by how women enter the EMR through all of these health centers. They may just show up to deliver their babies and not be previously observed in the EMR. We are working with the machine learning group on best practices. So one of the awesome things about being part of N3C is that there's methodological teams that support these types of efforts and really help us figure out best practices and provide input into how we can, get where we're trying to go. So after our cohort is defined, we're pursuing sort of these 3 questions just very soon, maybe this week. What is the overall test positivity rate at any point in pregnancy? We're trying to understand, does it vary by stage? And, due to delivering women being tested upon arrival in the hospital, we do think that it's likely that we'll see the highest positivity rate around delivery. But on the other hand, we think that looking at delivery actually addresses biases around who gets tested and why, and we may pick up asymptomatic cases. So we're sort of exploring that. And then we're next on our list is to start looking at severity of COVID-19 by pregnancy phase. Next slide, please. So I was asked to sort of give a sense of what kind of methods we're using for some of our questions. And our team is interdisciplinary, covering statisticians, informaticists, data scientists, economists, and epidemiologists, plus all of our clinicians. And so we're really bringing the whole gamut to some of these questions and thinking about what the best approach is. For folks who are interested in pregnancy-related questions for the knowledge store down the road, we will be making sure that our pregnancy concepts and maternal outcomes, infant outcomes will be there for others to use. And then down the road, we'll be incorporating publicly available data on the community and environment. And so we'll be collaborating with the social determinants of health and other teams that are trying to do this type of work to create best practices and better understand what some of the limitations are when we try to link external data to the EMR data in N3C. Thanks, I think that's it.
Terrific. On to Dr. Buse.
Thank you. So like David Ellison, I'm involved in our CTSA at the University of North Carolina. I'm one of the co-PIs, but I'm talking to you today as an endocrinologist specifically interested in diabetes. And the diabetes and obesity domain team on the next slide has now about 30 members. Some of the more recent additions we haven't added to this slide, but as has been discussed with the other domain teams, broad experience, people with a primary clinical or research interested in diabetes or obesity, as well as informaticians and statisticians and epidemiologists. Interestingly, the group includes people from the pharmaceutical industry, as well as Optum, another private concern interested in the healthcare arena. Next slide. So I'm going to tell you about one study in particular, because the one thing I have to add to what's been discussed already is the sort of concept of how you can put together a team to move forward from one of these domain teams. So we have a study that I'm going to show you in a moment that looked at novel glucose lowering medications in the setting of diabetes that have been associated with benefits on mortality and other outcomes in patients with type 2 diabetes in general. And this clinical observation could be important in the setting of COVID-19 because the people who seem to really benefit from these medications are the same people who really have the worst outcomes in the setting of COVID-19. So people with obesity, people with kidney disease, people with heart disease, and particularly heart failure. So the sort of core team that we developed involved me, who is a clinical trialist and a person who has participated in a lot of the trials associated with these drugs. Kaja Kvist, a statistician from Novo Nordisk, who was very helpful in developing the sort of statistical analysis plan. Trina Abramson, who's also at Novo Nordisk, who is had some Palantir experience in her previous work in the sort of informatics group at Novo Nordisk. And then Anna Kokoska, very importantly, an MD PhD student at UNC, who had the time and the bandwidth to really coordinate these activities and do a lot of the writing of the protocol and the subsequent paper. So the idea is to put together a team that has an interest in a particular question and to keep moving forward between calls to get to an analysis. As we put together the protocol, the domain team provided a lot of excellent input. So this 4-person group was expanded tremendously in the paper writing process, as well as the protocol development process. If I could have the next slide. So here is the title page of the paper that's under review. Next slide. And the sort of general concepts that we're looking at are whether these GLP-1 receptor agonists and SGLT2 inhibitors that have been associated with benefits in patients with diabetes who have risk factors, to see whether they are associated with differential outcomes as compared to DPP-4 inhibitors, another type of diabetes drugs that's very commonly used in diabetes. All of these 3 drug classes being so-called second-line therapies after the initiation of metformin. Next slide. And just to show you, one of the problems and the reasons why N3C is such a useful resource is, though we have a huge number of patients in N3C, and this data, the data that was used in the paper, I think, is from December 19th, so there's a bit more data now than there was then. Even though there's a huge number of patients in the resource, once you start looking at the inclusion criteria that you use in this kind of epidemiologic kind of study, you end up with relatively modest populations, so 5,500 patients, which will be by far the best analysis of a pharmacoepidemiologic outcome in the setting of COVID-19. Next slide. And this is just the sort of table 1, and I show you this just to focus on the age, and you can see that there's a substantial age difference, that the DPP-4 inhibitor users on the far right are substantially older than the GLP-1 receptor agonist users, which creates a real problem when you're using an outcome like mortality, where age is one of the biggest drivers. Next slide. So we use these statistical techniques to weight populations and use propensity score weighting, and you can see that we narrow the difference with regards to age in the comparisons quite well. We use other techniques to get it even narrower. Next slide. And I would just tell you that the data that's under review suggests that GLP-1 receptor agonists are associated with lower 60-day mortality compared to the DPP-4 inhibitors, was statistically significant and robust to various alternate analyses. The SGLT2 inhibitors showed very equivalent trends, but with somewhat fewer patients exposed, it didn't quite reach statistical significance. And this was also shown for total mortality, emergency room visits, and hospitalizations. Next slide. And I just want to mention that Carolyn Bramante, who is on the call, is looking at metformin, the first-line therapy. She has some wonderful data from other analyses, much smaller data sets, suggesting that there is lower mortality in the setting of COVID among people who use metformin. There's some preclinical data that suggests that that's also true, and she is working on analyses comparing metformin versus sulfonylureas and DPP-4 inhibitors, as well as some interesting analyses for patients who don't have diabetes, but are using metformin for obesity or polycystic ovarian syndrome. Next slide. And we have some other areas that we're focusing on. Our calls are the 4th Thursday of the month at 9 a.m. and we'd be delighted for others to join. There is need for additional clinical questions, but the greatest need is for people who have some informatics skills. There's a much easier path to subsequent publications after the first few are done. And so some people with modest informatics skills could really help move these processes forward. Thank you.
Terrific. So we're on to our Assistant Director of the Center for Data to Health, Anita Walden. We're going to try to make it quick since we only have 3 minutes. So please go ahead.
All right, I'm going to show you how to get involved. You just heard from a few of the domain teams. We actually have more than 20. So please go to our website to see the complete list. And if you don't see a domain team out there that you're interested in, you can start one and we can help you with that. Next slide. As you just heard, these teams are made up of statisticians and clinicians, and so we'll continue because you just heard from them. Next slide. But there's some other benefits N3C can provide, such as training. There are opportunities for KL2 and TL1 scholars. We just had a grad student who completed his capstone using N3C data, and we also had some other students that will be joining us too. This is also a great opportunity for those who are thinking about career advancement or career changes. That just provides a wealth of opportunities for you to participate. In addition to that, this is also an opportunity to collect pilot data for grant submissions. And if you have an algorithm that you need to train on a larger data set, this is a great opportunity to do that. And then I don't know about you, but sometimes, I have a hard time getting access to our own EHR data. So not only do you have access to one institution's EHR data, but you have access to large scale COVID data. Next slide. If you're interested in some of the existing projects, there is a list of projects on our website. You can go to our website and look at them. And then once you're in the enclave, once you get an access to the enclave and get an account, you can actually request to collaborate with any one of these project teams. There are a few project teams that may not be open for collaboration, but feel free to reach out to the investigators who are listed on the website and see if you can collaborate with them. Next slide. All right, so a few of our resources. So if you're interested in domain teams and you're interested in creating a domain team, we can help you with that. We can help you set up a workspace. We can also help you with creating a listserv and also a Slack channel for communication. There are also templates out there that the other domain teams can share for IRBs. And then also we have some slide templates for you to use as well. And if you need some help with setting up a meeting, our group can also help you with establishing your recurring standard meetings. Next slide. All right, now to access the data portal, you can keep pushing on this one, Connor. So to gain access, 3 things. You need a data use agreement. You need to register and create an account for the enclave. And also you need to submit a data use request. And so the data use agreement, your organization needs to have one with NCATS. If you want to know if your organization has a data use agreement in place, you can go to our website and look there. If you do not see your organization listed, then you can, there's some general instructions there that you can set up your agreement with NCATS. Once you have that in place, you can create your account, and there's some training that's required. Next slide. Before you actually can go in and submit your data use request. So we created what's called an enclave checklist. It's on our website. The enclave checklist gives you a list of things you will need to do before you can actually submit your first data use request. And so we thought this was helpful because there are a couple things and a little bit of training and a couple of documents you need to have in place. But if you have questions, we also have training office hours. Our N3C coordinator, Sean O'Neill, can actually help answer any of your questions. The office hours are Tuesdays and Thursdays from 1 p.m. to 2 Eastern time. But there are also other training opportunities. We have tutorials that are available. Some are actually in the enclave because it's just easier to navigate in the enclave and look at the information that's the structure of the enclave there. And there are a couple of tutorials that are outside of that. We do have an orientation coming soon. We're piloting it now. It should be available early February, so please look out for that. It's designed, there's 2 parts. It's designed for those who are brand new to N3C and for those who had a data use agreement data use request approved. There's one there for you. Next slide. If you can also work with local teams within your institutions. And so there are a number of ways to do that. We do have some materials there for your use, like newsletter templates, media kits. NCATS also has some communication media tools and a web page builder. So if you want to, facilitate more information or facilitate engagement within your organization, here are some tools to help you with that. Next slide. And if you're interested in the operations at N3C, we have work groups that are available, such as in data ingestion harmonization, collaborative analytics. If you're interested in governance, we have a governance meeting every Friday, and also synthetic data. We do have that available, and you can join those work groups. And the information is here on the slide and also on our website and our calendar. Next slide. So we're here to help you, and especially to fight this pandemic. So just let us know what we can do to help you get engaged. Dr. Shute?
Thank you. As you can see, it really takes a village, and we are delighted with the cooperation and participation of the community. Multiple talent is needed, from data scientists to clinicians to everybody in between. As you can see, we have a participating meeting schedule that's enumerated here. This is just an example. The full domain calendar team is at that website and part of the open house process. This is just the kickoff meeting. We thank you for attending. We're delighted with the continued participation of the community, and we hope to enlarge it so that together we can all learn what helps and what hurts to make this serious pandemic better for all of us. With that, I think we are over time, and thank you very much.
Thank you all very much. We look forward to seeing you.
Thank you.